Urolithiasis, one of the great equalizers of discomfort, remains a prevalent condition worldwide, affecting up to 12% of men and 5% of women in their lifetime, and globally it's on the rise. The usual suspects, obesity, dietary changes, and even global warming, are to blame. The stakes are high for patients dealing with pain, infections, or surgical interventions, and the costs are rising too. In my webinar, I'll delve into current imaging strategies, highlight key radiological findings and pitfalls, and focus on how our tools influence clinical management, spotting the sick kidney, evidence-based management strategies, how to maximize your utility in the stone MDT. I'm going to finish with the principles of percutaneous nephrolithotomy, the uroradiologist's roles, techniques, tips, and tricks. During the UK resident doctors' strike, senior stone surgeons had to act down, and one of them confessed that most of what they had to do revolved around radiology, requesting and reviewing scans and organising interventional radiology procedures. Radiologists are the linchpins in the management of urolithiasis, ensuring accurate diagnosis and guiding appropriate treatment to prevent complications like infection and chronic renal impairment. Imaging isn't just a helpful tool, it's essential at every stage. Diagnosis, identifying the presence, location and characteristics of urinary tract calculi. Pre-treatment planning, providing detailed roadmaps for interventions like percutaneous nephrolithotomy, ureteroscopy or shockwave lithotripsy. Treatment itself as in nephrostomy, stents and PCNL. Post-treatment follow-up, monitoring for residual stones, complications or recurrence. Let's start with the humble CT-KUB, which this evidence from the European Association of Urology proves is the gold standard for diagnosing stones. It has relegated IVU to the pages of medical history textbooks and is vastly superior to ultrasound. As radiologists, we hold the key to this diagnostic powerhouse, providing clinicians with critical details like stone size, location and density, all the things they need to look decisive in front of their patients. CT-KUB also excels at detecting X-ray radiolucent stones like uric acid and xanthine, though not indinavir stones. Its ability to assess skin-to-stone distance and surrounding anatomy makes it invaluable for tailoring treatment plans, though let's not forget the trade-offs. No renal function data, and there is a small radiation dose, the equivalent of 3 months of background radiation or a dozen flights across the Atlantic if you are using ultra-low dose. It delivers superb accuracy for patients with a BMI under 30 and 100% accuracy for stones more than 3 millimeters. For those who crave more complexity, dual energy CT lets us flex our diagnostic muscles by distinguishing uric acid from calcium stones. So while the urologist is king in theatre, it's the radiologist who makes it all possible. Ultrasound certainly has its moments in the spotlight when it comes to renal stones, especially for pregnancy and pediatric cases where minimizing radiation is the key. It's also handy post-procedure, checking for obstruction. But when it comes to small stones less than 5 millimeters and ureteric stones, it is not exactly ideal. On the right, we have an example of the twinkle artifact, which is highly operator dependent and prone to conjuring up phantom stones, resulting in not an insignificant number of false positives. Ultrasound tends to overestimate stone size, especially for smaller stones. MRI isn't exactly the go-to modality for spotting stones. They typically appear as signal voids on T1 and T2 weighted sequences as above, which, whilst suggestive, aren't particularly specific. Filling defects could be something more worrisome, like a tumour, though contrast-enhanced imaging, when appropriate, can help distinguish the two. Stones don't enhance. That said, MRI does have its place. With no ionizing radiation, it's particularly useful in pregnancy, pediatrics, or for patients needing a repeat imaging. It may not provide the clarity of CT, but in certain cases, its safety profile makes it a sensible alternative. A tool in the box, if not the sharpest one. What should be in your CT-KUB report? The essentials. It's not a complicated scan, but that does not mean we can skip the details. The headliners are number of stones. Count them all, yes, even the tiny ones. the urologist might want to go after them, especially if no other cause for pain exists. Location. Be specific. Renal pelvis, upper, middle or lower pole for kidneys, proximal, mid or distal ureter for ureteric stones. Size. Measure in 3 planes. Maximum diameter wins the day. Density. Is it a shockwave lithotripsy friendly stone or an uncooperative calcium oxalate monohydrate? Your Hounsfield unit holds the answer. Skin to stone distance. Shockwave lithotripsy planners love this. Longer distances mean lower success rates, so save them the guesswork. Secondary findings. Hydronephrosis. Mild, severe, be descriptive. Fat stranding, perirenal or periureteric. Highlight the inflammation. If you are really dedicated, you could mention the anatomical challenges such as narrow infundibulum or steep infundibular angles. Report every stone, even the small ones. There is a clinical relevance. Even small stones might be the target if there's no other explanation for the patient's pain. The total number and size of stones directly impacts management decisions. A high burden may mean that the patient requires multiple procedures or additional planning. Urologists rely on accurate imaging reports to have informed discussions with patients about treatment options, expectations, and outcomes. Why should we report stone size? Because size predicts spontaneous passage in the ureter. As a general rule, ureteric stones less than 5 mm have a high chance of passing on their own. Stones greater than 5 mm have decreasing odds, with intervention often required. Size thresholds influence choice of intervention. I will talk about this in more detail later. Monitoring progress. For patients under observation, knowing the stone size allows for comparison over time. Growth or stability helps determine whether intervention is needed. Post-treatment follow-up relies on size reporting to assess residual fragments. The management of stone disease often hinges on stone size. Accurately assessing stone size can be tricky as studies show significant variation depending on window settings. Bone window settings are far more accurate, offering sharper edge delineation and less overestimation of size. Abdominal window settings tend to overestimate stone size, potentially leading to unnecessary escalation in treatment planning, as in this case. My best practice for stone measurement? Use bone window settings. Measure in 3 planes, focus on the maximum diameter. If you want to look really clever, correlate axial measurements with stone passage likelihood. There are some studies suggesting that axial measurements correlate best with predicting whether a stone is likely to pass spontaneously. Long but narrow torpedo-shaped stones are more likely to pass. Pay close attention to the anatomical narrowings of the ureter, the most common sites where stones get lodged. Pelviureteric junction on the left, pelvic brim in the middle, and vesicoureteric junction on the right, the narrowest part of the ureter and a frequent trouble spot. At my institution, it's routine to describe renal calculi by their location, upper pole, mid-kidney, or lower pole, as you can see on the left. When reporting, provide precise locations as treatment options often vary based on stone position. There is a key division for renal stones, which is illustrated by the blue line that divides the lower calyx from the rest of the kidney, as in the diagram on the top left. Stones in the lower pole calyx have different treatment options than if they were elsewhere in the kidney. There are specific anatomical quirks impeding clearance, particularly with shockwave lithotripsy. For ureteric calculi, we describe stones in the proximal ureter, that's from the PUJ, the pelviureteric junction, to the superior margin of the sacrum. Mid-ureter from the superior margin of the sacrum to its lower margin, and distal ureter from the lower sacral margin to the VUJ, that is the vesicoureteric junction. Proximal stones are less likely to pass spontaneously, often requiring intervention. Distal stones have a higher likelihood of passing naturally. Of course, size matters. CT has revolutionized stone detection, but when it comes to stone compositions, things get a little fuzzy. The go-to method relies on measuring the mean attenuation value, i.e. the Hounsfield units, of calculi using a region of interest. It works well for straightforward uric acid stones, which typically range from 200 to 450 Hounsfield units, making them prime candidates for medical management with urine alkalinization. It works well for calcium phosphate stones, clocking in its dense 1,200 to 1,600 Hounsfield units. But we can struggle with getting it right because of the mixed composition of many stones, because stones don't like to stick to one mineral type, the challenge of precise region of interest placement, particularly for smaller stones, and the lack of standardization in Hounsfield unit measurement techniques. Avoid pixel measurements. Region of interest just takes a few more seconds. My recommendations? Use zoom and set the bone windows for clear edge delineation. Measure in a representative plane and stick to a single region of interest technique. CTKUB often gets a reputation as a Swiss Army knife for acute abdominal pain. It's frequently cited as a great tool to exclude extrarenal causes of discomfort. In fact, around 10% uncover an alternative cause for the pain. That's not trivial, but let's be clear. CTKUB is not and should never be a screening tool for abdominal pain. Here's why. Ultra-low dose, non-contrast studies are designed for stones, not for subtle appendicitis, as in on the left, or bowel tumours, as in on the right, and definitely not gynecological pathology. It's just not the right tool for the job. In my opinion, if subtle pathologies are missed on a CTKUB, I do not think it negligent. That's simply the limitation of the modality. The onus then shifts to the clinical team. They are duty bound to investigate further if symptoms persist or don't fit the radiological findings. So while CTKUB has its place, let's not overburden it with expectations it was never meant to fulfill. Use it wisely and do not let it stand in for broader clinical judgment. I'm now going to show you some common pitfalls. Knowing them helps ensure accurate interpretation, avoids unnecessary interventions, and keeps surprises to a minimum both for you, the urologist, and the patient. Thick slices. On the left is a thick slice showing a single stone. On the right is a thin slice revealing an otherwise occult smaller stone. I know why we use thick slices. We have busy lists or we are remote reporting with clunky scrolling. The temptation is to review the thick, less numerous slices. Don't. Always thin slices. They are excellent for spotting renal calculi. There are fewer partial volume effects, better accuracy. The downside? They can occasionally point out things that aren't really there. Increased noise can simulate small calculi, especially if scuppered by a motion artifact. Supine versus prone views. On a supine view, when a calculus is near the vesico-ureteric junction, it can be a bit tricky to determine whether it's part of the prostate or lodged in the intramural ureter, as in the top left supine slice. This is where the prone position comes to the rescue. In the prone position, you allow gravity to do its diagnostic work. If the stone has passed into the bladder, it will conveniently settle in the anterior bladder, making its location much clearer and differentiating it from prostate calcification as in the first column of images on the left. If it's lodged in the VUJ, it will stay in the VUJ as in the second column of images on the right. My recommendation? All CTKUBs to be done prone. It's a simple adjustment, but one that ensures that your report is precise. There are two signs that can help differentiate a urinary calculus from a phlebolith. The first is the soft tissue rim sign, a reliable indicator of a ureteric stone. It shows up as a rim of soft tissue attenuation caused by ureteric irritation. For phleboliths, the comet tail sign is a dead giveaway, with a tapering soft tissue streak pointing to the non-calcified part of a vein. Caution, it's not always there. Central lucency is another hallmark, though admittedly rare, but when it shows up, it's phlebolithic. Shape helps too. Phleboliths are rounded, while stones are denser and more angulated. In this 2 rows of images, the top row are stones. The bottom row are phleboliths. It's still not that clear, right? There are times when the CT-KUB leaves us in diagnostic dilemma. Perhaps the distinction between a stone, a phlebolith, or another structure isn't clear, and a management decision hangs in the balance. In such cases, a urographic phase may be the only way forward. By adding contrast, a urographic phase can provide critical clarity. It delineates the collecting system, helping confirm or exclude the presence of a stone. It highlights the hydronephrosis, which may shift the clinical approach. While it's not ideal to add another phase and the associated radiation, it's often a necessary step to ensure that the patient receives the right treatment. This small inconvenience can prevent missteps in management later. Vascular calcifications can occasionally masquerade as renal stones. Typically linear in appearance, they can often be traced along the renal artery branches neatly nestled within the vessel wall. Patients with vascular calcification usually provide further clues, a generous sprinkling of calcification elsewhere, such as the splenic artery, or in this case on the right, the aorta. It is simply a case of pattern recognition. Let's talk about Randall's plaques. I find them tiny troublemakers lurking in the renal papilla. These subepithelial calcifications are considered a predisposing factor for renal stone formation. They are usually asymptomatic and don't always progress to stones. My radiographic features to spot Randall's plaques: size, surface, and location. They are tiny, less than 2 millimeters, with at least 50% of their surface embedded in renal parenchyma. This is a really important sign, as you can see in this image. The location, always nestled within the renal papilla. Complications. Hydronephrosis is the most common, caused by an obstructing stone in the ureter. It can be obvious, but it can also be subtle, as in this case. Compare the left kidney to the right kidney. The blunting of the calyces and the effacement of the renal sinus fat are the clues. Compare the hydronephrotic left kidney to the preserved calyceal fat and sharpness of the calyces on the right. Other signs include perirenal and periureteric fat stranding. When the ureter gets inflamed, the adjacent retroperitoneal fat becomes edematous, and there is stranding, as seen on the 2 slices on the right. Mimics of hydronephrosis. The 2 main ones are the extrarenal pelvis and parapelvic cysts. Interrogate the renal sinus carefully if you want to differentiate the mimics of hydronephrosis. Interrogate them particularly at the upper and lower poles. Here, the right kidney is not hydronephrotic. These are parapelvic cysts. Look at the sharpness of the calyces, how that is maintained. Look at the sinus fat. It is compressed, but still well defined. This is most conspicuous on the coronal sequences. Spotting the sick kidney. Look at this axial view of the CT-KUB on the right. The left kidney's renal sinus fat is effaced. Calyces are blunted, consistent with hydronephrosis. Also, the linear high-density streaks in the perirenal space, and you've got classic perirenal fat stranding. Added to this, there is gas, indicating emphysematous pyelonephritis. Other clues you should look for: a thickened renal pelvis wall, and fluid within the collecting system that is usually higher than the density you expect for urine, indicating it is likely to be pus. These are red flags. But wait, CT alone isn't enough. Pyelonephrosis can be subtle. The real giveaway? A clinical picture of infection in a sick patient. When CT and clinical findings combine, you're looking at pyelonephrosis until proven otherwise. Your role is to identify the signs of infection, highlight them, and convey the findings urgently. Managing pyonephrosis. Timing is everything. First things first, we must drain the swamp. If the patient is septic or heading towards renal failure, immediate drainage is non-negotiable. There are two options, the ureteric stent or the trusty percutaneous nephrostomy tube. The literature comparing these modalities and treatments is sparse, based on small cohorts. The success and complication rates for ureteric stent and nephrostomies are pretty much identical for both options. The time to recovery, there's no significant difference for patients presenting with fever. Hospital stay, nephrostomy patients stay longer. Quality of life, stents are the biggest buzzkill thanks to stent-related symptoms. Both options decompress the kidney and depend on local availability and patient suitability for anaesthesia. A recent UK BAUS national nephrostomy audit does not mince its words. Delays in diagnosis and drainage lead to worse outcomes. In other words, do not dawdle. When to intervene? Beyond observation. We intervene when there are growing stones. Stones that are getting bigger never lead to anything good. Intervention prevents future obstruction and complications. Intervene in obstruction. Stones causing significant blockage in the urinary system demand prompt action to protect renal function and avoid worsening symptoms. Infection. Stones associated with infection require urgent intervention. Delay could lead to sepsis, then death. Symptomatic stones, even small stones causing persistent symptoms, need to be addressed, but only after ruling out other causes for the pain. Social considerations. Sometimes lifestyle factors dictate intervention. Patients who fly frequently or whose professions depend on reliable health may prefer a proactive approach to avoid an unplanned stone emergency. So, these are practical flow diagrams that you can peruse at your leisure. They are useful evidence-based algorithms. Renal stones are on the left, the treatment of ureteric stones are on the right. But for us radiologists who perform PCNLs, in general, if a symptomatic renal stone is 2 centimeters or more, it's likely heading for a PCNL. If it is less than 2 centimeters and unsuitable for surgery or shockwave lithotripsy, it is likely heading for a PCNL. Where do we decide this? In the stone MDT. Here we discuss the percutaneous nephrolithotomy. The two principles of PCNL are simply safe access and the best approach to maximize stone clearance. PCNL planning is like assembling a crack heist team of boffins where we all have our special set of skills. The radiologist points out where the stone is hiding, its size and how much chaos it's causing. The urologist and radiologist decides the best approach to remove it. The anaesthetist who is not present will have already determined whether a supine position is possible and grade the risks ensuring the patient survives the ordeal. We plan efficient resource allocation, ensuring that the theatre has everything needed: ultrasound, access sheath, dilators, C-arm, radiological equipment, and of course the one essential piece of kit that's always missing unless someone explicitly asks for it, the radiographer. The MDT leads to improved patient outcomes. No unexpected curveballs mid-procedure because someone has already spotted the awkward access angle or the sneaky anatomical anomaly. There are fewer complications, happier patients, and fewer emergency, out-of-hours CTs to report. The Stone MDT provides an excellent forum for enhanced education. It is great for teaching juniors. Nothing drives home a point like watching the team argue over a Randall's plaque. When you have decided that the stone is big enough and hard enough for a PCNL, you have reviewed the CT and are confident that you can access the stone and maximize clearance, you've minimized the risk of any nasty surprises, particularly in your percutaneous path. But in addition, you can reference the Guy's stone score. It's the urological equivalent of a difficulty rating system for PCNL. In summary, grade 1. I'm just a lonely little stone in a single calyx, no drama here. Straightforward and predictable. Grade 2. The stone has brought a friend, or two, maybe in the renal pelvis or another calyx or a solitary kidney. Slightly more demanding, but still manageable with a bit of effort. Grade 3. I'm a partial staghorn, or maybe a calyceal diverticulum, or there has been previous surgery with scar tissue. Could be a bit of a problem, but not impossible. Grade 4. Full staghorn in a kidney and or annoying anatomical anomalies. This is going to be likely messy, unpredictable and exhausting. Spotting the clues on imaging can predict how much fun for you and for the urologists the procedure will be. Contraindications to PCNL. While PCNL is a highly effective treatment for renal stones, certain situations make PCNL less suitable. Here is what to keep in mind. Uncorrected coagulopathy. PCNL involves a high risk of bleeding, so patients with clotting disorders must have these corrected before the procedure. Ensure there is some recent coagulation you can check. Untreated infection. Active urinary tract infection should be treated with antibiotics prior to the operation. Pregnancy. PCNL is contraindicated in pregnancy due to radiation exposure and the potential risks to the fetus. Tumor, either in tract or kidney. Remember, 30% of renal cell carcinomas demonstrate calcification. If in doubt, get a post-contrast study. The top left CT is a patient with loin pain. The CT-KUB was reported as renal stones, and the imaging was referred to the stone MDT. We had a close look at the left kidney and we felt the surrounding tissue was too prominent for a dromedary hump and a little too dense. We decided to administer intravenous contrast, which revealed a calcified tumor. So now that the counting, the measuring, the crying and arguing is done and we've come up with a plan, we need to decide where to do it. The team approach in our centre has undergone an evolution, moving from a staged process to a more integrated approach. Initially, the procedure was split. The radiologist would gain access and place a nephrostomy in the interventional suite, capitalizing on the superior fluoroscopy equipment and having the full nephrostomy kit at hand. The patient would then head to theatre for the tract to be dilated and the stone removed. This setup ensured that the urologist and the anaesthetist didn't spend their time waiting for access to be established in theatre. However, there were issues. Without the urologist's retrograde pelvic system distension, gaining safe access in mostly undilated kidneys, particularly with staghorn stones, was difficult. Scheduling changes. IR emergencies displaced some cases, leading to frustrating cancellations. Patient discomfort, a big one. The nephrostomy tube placed preoperatively often caused significant pain for the patients during the wait for their surgery. The solution? I now dilate the tracts in theatre. I now form and dilate the tracts in theatre. I have improved access, enjoying the urologist's retrograde distension of the pelvic calyceal system. This allows quicker, safer and less bloody access. Streamlined logistics. Theatre is equipped with an excellent ultrasound machine, a well-stocked access kit and a rotating C-arm that provides satisfactory visualization without issue. Patient comfort. The access to stone extraction phase is now swift, seamless and significantly less painful. My top tip, make sure that you are in theatre for positioning supine patients, otherwise access can become incredibly annoying. Choosing between prone and supine positions is about practical advantages. As radiologists, we need to ensure safe access. If you can't get to a stone without skewering or bursting something you don't want to, then don't. The decision has been made for you. The evidence says that both supine and prone are equally safe, but that does not mean that both are equally feasible. Plan access with your surgeon and more often with your anaesthetist. Evidence is that stone-free rates are comparable when comparing prone and supine, but the supine position offers a time-saving benefit with a shorter operative time. Supine PCNL also has the added bonus of allowing simultaneous retrograde access to the collecting system using a flexible ureteroscope. This makes it particularly appealing when combining PCNL with a retrograde procedure, a strategy that shows promise for treating complex renal stones. Other positions are available after discussion with the anaesthetist. Standard or mini? Meta-analyses comparing mini PCNL with standard reveal that both techniques achieve similar stone-free rates. Mini PCNL, however, brings some additional perks: reduced blood loss, lower transfusion rates, and shorter hospital stays, all without a significant increase in complication rates, but a significantly longer procedure time. This may be a win for patients and perhaps for the hospital bed manager, but not for the waiting lists or my afternoon CT inpatient list. That says, the evidence does come with a caveat. Data heterogeneity stemming from variations in tract sizes has led to some downgrading of confidence in these findings. Ultrasound or fluoroscopic puncture? Fluoroscopic puncture remains the old faithful of the old faithful. By that I mean the urologists. But ultrasound has elbowed its way into the spotlight. Ultrasound-guided puncture not only spares all participants from unnecessary radiation, but also comes with the added bonus of fewer complications, making it a win-win. You can go transverse if the curvy linear probe is too big and the ribs and other organs are getting in the way, as you can see in the bottom row of images. But when you go transverse, you can't see the whole length of your needle, and needle tip localization can be erratic, so beware. If ribs are getting in the way, maybe try a different probe with a smaller footprint. I sometimes use the transcranial Doppler probe, a very small footprint and more than adequate depth, as you can see in the ultrasound image. A colleague has also suggested a needle guide being a game changer. We've just put in our order. Needle choice. This is all about personal preference and experience. I personally stick with the standard MAC non-vascular micropuncture set on the left. It has an echogenic tip. It lets me upsize seamlessly from an 018 to an 035 wire, which is the same setup I use for nephrostomies. I find familiarity breeds confidence. The introducer buddy passage of my 035 wire alongside my 018 wire keeps access secure. The hydrophilic 018 wire glides beautifully through tight spaces, particularly between impacted stones in the urothelium, and it does not tend to deform easily. Minimal resistance, minimal drama. For those looking to switch up, there's the Kellet needle on the right. It's a slightly larger 19 gauge needle, offering a bit more size and authority. There is no definitive data to say which size is safer or easier. It's more about what works in your hands. The importance of tract angle in PCNL. When planning your tract, the angle is everything. A well-chosen tract ensures efficient access to the collecting system, facilitates stone clearance, and minimizes complications. However, a poorly angled tract can turn a straightforward procedure into a wrestling match with the kidney. A straight aligned tract allows instruments to navigate freely, especially rigid nephroscopes. Acute angles force the surgeon into awkward maneuvers, increasing the likelihood of leaving fragments behind. Overly angled tracts place significant torque on the kidney during nephroscopy. This can lead to unnecessary parenchymal stress or even cause the kidney to shift, increasing the risk of complications like bleeding or infundibular damage. Super 12th. Sometimes you've got no choice but to go above the 12th rib for access. Previously avoided, it's not as risky as it seems, especially with ultrasound. Here's a quick look at the ups and downs of taking the high road. The advantages: improved upper pole access, a straighter shot to the upper calyces or renal pelvis, sparing the nephroscope from awkward contortions. Enhanced stone clearance, it's perfect for staghorn calculi or complex stones, more collecting systems are covered. And disadvantages: thoracic complications, yes, there is a chance of pleural puncture or a pneumothorax, but that's why we bring the chest drain to theatre, right? Technical challenges: intercostal access can be technically challenging. Respiratory irritation: a little diaphragmatic irritation might complicate ventilation. Give the heads up to the anaesthetist. During the percutaneous access, dilating the percutaneous access tract during PCNL can be accomplished with metallic telescopic dilators, as in on the right, single-step dilators, or balloon dilators, as in on the left. Fortunately, safety and effectiveness are similar across all methods. Blood loss is higher in telescopic dilators. Costs are higher with balloons, which means that the choice is often down to personal preference and experience. The fine art of balloon dilatation, the most traumatic part of the procedure. I rely on the 30 French Nephromax high pressure balloon. Placement is everything. If it's too short, the balloon stops into the parenchyma. Inflating it there will lead to serious bleeding. Advance it further into the calyx, reinflate and gently screw the sheath into a better position. Too far. If you overshoot the infundibulum, you risk rupture. Here we see a PUJ rupture where the dilators went in too far. A retropyelogram is your friend here. Check for signs of a thin infundibulum before proceeding. Inflation and wasting. Inflate the balloon with dilute contrast under fluoroscopic guidance and keep an eye out for areas of resistance, otherwise known as wasting. There are 3 key locations. The skin. Maybe you made a too small incision. Time for a bigger nick with the scalpel. The fascia. If the fascia resists, a deeper incision might do the trick if you dare. Capsule. There is no cutting here. Just keep inflating until the balloon does its job. My tip: do not bother advancing the sheath until the balloon is fully inflated. In one of my cases where the sheath refused to advance, I swapped the balloon dilators for metal dilators, and it worked. Sometimes you just need to go old school to get the job done. Now, robust wire placement, it forms the foundation of reliable PCNL access. Getting that stiff wire securely into the distal ureter or bladder is the foundation for successful PCNL. Why? Because it's your safety net. If the access sheath is displaced during the inevitable back and forth wrestling with the nephroscope, the wire ensures you can re-enter the system without a panic. Also, the wire is a guidepost. The urologist will appreciate knowing that the wire is pointing south, helping them orientate themselves amidst the chaos. What about wire tips and tricks? The first one is when the wire won't advance into the system. Perfect wire placement is challenging. Common obstacles include the wire not advancing through the needle. Either you're up against a stone or you've missed the system altogether. How do I get around this? I let the urologist help. Retrograde filling to create more space between the stone and the calyx often does the trick. The image on the left shows the needle in the right position, but my 018 wire not advancing. Image on the right is after retrograde injection of 10 milliliters of contrast via the retrograde catheter, and this is shown by slightly more fullness of the pelvis and calyces. The wire then slipped right past the staghorn to curl within the confines of the pelvis. If your wire isn't going, you could adjust the needle. You can rotate the bevel, advance or retract slightly. It's a finesse game, not brute force. You could switch to a more reliable wire. My go-to wire is the 018 Terumo Glide wire. It has an hydrophilic tip and stainless steel core, and it's excellent for those tricky cases. It's slippery yet sturdy, and it's designed for navigating tight spots. And then there is the nuclear option. When all else fails, swallow your pride and repuncture. Yes, it's annoying, but a fresh start is better than stubbornly persisting with a less than ideal setup. What about when the wire won't leave the calyx? Getting your wire into the ureter can be frustrating. It happens when the infundibulum is tight or blocked by stone, or the urologist is blocking the PUJ with the retrograde catheter. Here is my two-pronged approach to solve this problem. Method 1, the loop gamble. I curl as much of the L18 wire as I can into the pelvis. This creates a radial force which might coax the wire to pop into the ureter. Method 2, the radiologist's ace. If the loop gamble doesn't work, exchange the 018 wire for an 035 wire to give you better stability and rigidity. Over the 035 wire, I advance an 1/8 inch bright tip sheath. I insert the tip of the sheath to the pelvis to create a stable working channel, and then through the sheath I use a short directional catheter and glide wire. With the sheath in place, the 018 glide wire is deployed, and this combination offers excellent steerability, helping me navigate down the ureter. Complications. PCNL, while effective, isn't without its risks. A systematic review of nearly 12,000 patients highlights the most common complications as shown. Fever and sepsis. Fever may occur even with sterile preoperative cultures and antibiotic prophylaxis. Why? Because the stones themselves can harbour infection. Bleeding remains a concern, though minor cases can often be managed by clamping the nephrostomy tube. For more severe cases, superselective embolization may be required. Postoperative pain. Peripheral nerve blocks have been shown to significantly reduce postoperative pain and the need for opioids. I preemptively infiltrate chirocane around the tract. Now, special consideration should be given if asked for multiple tracts for larger stone burdens. The risk of complications, including pleural damage, infections, and transfusions, increases. This trade-off highlights the importance of weighing the risks against the goal of rendering the patient stone-free in a single session. I suppose I should mention the urologist. They are not like surgeons, they are actually much nicer. Now, I've had the privilege of working with skilled urologists for many years. We understand each other's limitations. They know the quirks of my equipment, and I must know the constraints of theirs. Planning access for PCNL isn't just about a safe tract, it's about making it effective, and that often means accommodating the tools your urologist prefers. I need to consider the tools in their arsenal. The rigid nephroscope, the workhorse for large stone burdens. It is bulky, but it allows for intact extraction of larger stones. The catch, it's a steel rod, so my access needs to respect its rigidity. Enter flexible scopes. Our urologists have flexible cystoscopes and ureteroscopes that can seemingly do yoga, as you can see on the bottom right. This is very useful in isolated calyces, especially with tight or long infundibula. But the view is worse because it's smaller, and fragmenting the stone means that the procedure takes longer and will likely need post-procedure drainage. So as you plot your access, keep this in mind. The urologist depends on you to open the door, and it is always better if the door swings wide enough for their tools to fit, preferably without a struggle. Post-operative drainage. The question of whether to place a large bore nephrostomy, such as a Porges tube, or a ureteric stent is entirely in the urologist's domain. The decision hinges on these factors as shown. So while these decisions fall to the urologist, teaching them how to place a ureteric stent through the sheath can be a lifesaver, yours specifically. Why? Because it spares you from having to stay until the bitter end of every case. So these are my tips on how I make a graceful exit. In most PCNLs, the interventionalist's involvement concludes when the urologist spots the stone at the tip of the nephroscope. At this point, I exit the operating room, leaving the urologist to handle the less fine details. Occasionally, things don't go quite as planned and I may be summoned back. Common reasons have included residual stones. If an awkward mid-pole stone remains stubbornly inaccessible, I may need to assist with creating either a new access point, but first I try pushing the stone out with a thin needle under ultrasound guidance, displacing it from the calyx into the urologist's view so they can grab it. It saves me making another tract, which can be incredibly messy and difficult. Other reasons why I could be called back: uncertainty. A new urologist is unsure about a complete clearance. My expertise may be called upon to clarify. This doesn't happen much. More often, I'm called the next day to review the obligatory post-PCNL out-of-hours CT. And sometimes I get asked to embolize an active bleeder. My interventional list has been cunningly arranged the morning after the PCNL to allow for this. I hope you have found this useful, and I thank you for watching.